My name is Radonna Chandler, and I work at the National Institute on Drug Abuse. It's a pleasure to be here with you all today, talking about this very important topic of women and addiction. I want to start by thanking Senators Whitehouse, Portman, Ayotte, and Klobuchar for hosting this event, and I am particularly pleased that they have chosen to start this panel with science, with evidence about what we know with regard to the etiology and the treatment of substance use and addictive disorders among women. I work, as I said earlier, at the National Institute on Drug Abuse, where we support almost all of the research that's conducted around the world on substance use and addiction. And it is very important, we believe, to build an evidence base so that those who are struggling with addiction can have treatment provided to them that we don't just think it works, we don't just believe it works, but our data indicate that it is effective and can be helpful. Everything from behavioral treatments to medications. And I am pleased this morning to have the opportunity to be the moderator for this panel and to start by introducing Dr. Christine Grella, who is from the University of California in Los Angeles. She is a professor in the Department of Psychiatry, and she is also the Associate Director of the Integrated Substance Abuse Programs. I've known Dr. Grella for many, many years. She has a long history of research where she has examined substance use and treatment utilization, and the relationship of service delivery to treatment outcomes. She has focused particularly on women who are involved in the criminal justice system, and on some of the deleterious outcomes, including homelessness and co-occurring mental health disorders. She is very widely recognized on the national and international stage. She is well published, and it is a pleasure to have her lead this panel this morning. Ready?
Thank you, Radonna, and I want to thank the organizers of this session. And I'm very, very grateful to be here today to talk about a topic that I feel very passionate about. And my job today is to give you an overview of the issues concerning addiction treatment for women. Let's move to the next slide. And as is fitting, I like to begin with a historical moment. This is a picture of the first addiction treatment program for women in the United States. It was called Martha Washington House. And you can see from 1869. And the image is one of a very bucolic, beautiful rest home. Most likely the women going into this program were addicted to opiates, which were freely available at that time. Next slide. This contrasts with an image from several decades later, from the Federal Narcotics Farm that was established in Lexington, Kentucky. The federal narcotics farms were the first federal drug treatment programs in the United States. Only about 10% of the patients were women. This was a combination hospital penitentiary. But I think this image says so much about the issues that we confront with the topic of addiction in women. You can see this young woman who's holding her face in shame. And we've heard discussion about stigma and its association with addiction for women, and I'll be talking about that in my presentation as we go on. Next slide. So my topics that I'm going to cover have to do with giving you an overview on the prevalence of substance use disorders among women and men, treatment seeking and barriers to treatment seeking, the clinical profile, treatment programs and services available, retention and outcomes, and service system issues. So I'll begin with just some basic facts about the prevalence of substance use disorders among men and women. Most of the data that I'm presenting today comes from national survey data sponsored either by SAMHSA or by NIH. Here we see the prevalence of lifetime drug use disorders among men and women in the US population. And there is roughly a 2-to-1 ratio of drug use disorders, with men having approximately double the prevalence of drug use disorders, although that has been lessening in the most recent years, particularly as we've heard already today around prescription opiates and stimulants. If we move to the next slide, we'll see a similar slide on the prevalence of past years' substance use disorders, including this time alcohol. So again, roughly a 2-to-1 ratio, but increasingly among some of the illicit drugs and prescription drug users, a closing of that gap. Let's move on. So then the question is treatment seeking. What proportion of those who have these disorders in the population actually seek out some kind of treatment? So in the first slide here, the first half of the slide, we can see that about 6% of the US population of women aged 12 and older meet criteria for a substance use disorder meriting a need for treatment. So 6%. So the question is, of those, how many actually receive treatment? And it's a well-known and very robust finding that about 85% of those with a substance use disorder actually never receive or do not seek treatment for their disorder, usually out of denial or minimizing the problem. About 11% of women do receive some kind of treatment, and about 5% say they have a problem but they didn't seek help for it. So let's move on and see what are some of the reasons. This actually is another slide showing a broader range of help-seeking disparity. For the lifetime, over the lifetime, about a quarter of women with a substance use disorder will seek some kind of help compared to about 31% of men. So we know there's a disparity in help seeking. So the question is, what are the reasons for that disparity?
So we're going to take a pause from Dr. Grella's presentation so that we can allow an opportunity for Senator Portman to come up and say a few words as one of the co-hosts of this event.
Donna, thank you. I was enjoying listening to that. So I didn't mean to interrupt you. I was sitting over there actually learning, which is always important in this field, given all the challenges that we have. So thank you all for being here. Donna, thank you. And to folks who are here today, we really appreciate your willingness to give us some advice and counsel. This is our second forum we've had. The first one resulted in such a wealth of information that we've actually started working on legislation in response to it, specifically focused on heroin and prescription drug addiction. And we are looking at introducing something probably in September. And we don't know exactly what the outlines of the bill are, but we have a pretty good idea based on the input that we've gotten. So if you have interest in following up with us on the general issue of heroin addiction and prescription drug addiction, we'd still love to get your input. Megan's here from our team. Jessica, how are you? Jess is helping on this and others, so please let us know. Senator Whitehouse and I will be introducing it. Senator Ayotte and Senator Klobuchar, are helping us to co-sponsor this event. And again, I appreciate the input that we're receiving, and I do hope to hear a little more myself. In our country right now, we have a quiet epidemic, and I use the word epidemic advisedly, but in my own state of Ohio, we'll probably have 2,000 people die of overdoses this year, and it's shifting, as you know, from prescription drug overdoses toward more heroin overdoses, and yet people really aren't focused on it. So by far the leading cause of death now, not just in Ohio, but probably in your state. We also have some really good evidence of what works and what doesn't work. And so what you'll hear today is, as you were starting to hear here, is some of the science behind this. And I think, frankly, one of the issues we've had over the years, and I've been involved on the prevention side for over 20 years now, including starting our own coalition back home that I chaired for about 9 years. But one of the issues we've had, frankly, is the lack of evidence-based approaches sometimes and the research to be able to ensure that we are putting the best practices to work. So I love these fora because it gives us an opportunity to hear from some of the experts, to get some of the science, to understand it better, and to be able to make more progress on these tough issues, not just on prevention and education, which I think is still the area that deserves the most attention relative to what it's getting, but also obviously on treatment and recovery. and what works and what doesn't work. So again, I thank you very much for being here. This is a specific focus today on women and how, as I just heard, to get more women into treatment, because there's often the sense of denial or concern or embarrassment or stigma, and then also trying to get women more involved on the prevention education side and on the recovery side. We think in the United States of America today, about 18 women die each day from overdose, and that has increased by about 400% since 1999. So again, it's kind of a quiet but very real problem that requires much more focus. Lori Chris is here from the Ohio Council of Behavioral Health and Family Services Providers, and I appreciate her coming. And Margot Spence is from First Step Home in Cincinnati, which is a great residential and out-treatment program in Ohio. And finally, Pamela Tropiano is here from CareSource Ohio to talk about her work on drug and alcohol addiction treatment. So I'm proud of Ohio for being at the cutting edge. I just again, thank everybody for coming today. I don't want to get in the way of further information here from our panelists. And again, we look forward to working with you on this legislation we're hoping to introduce in September. I'm sure we'll get more information today about that. And in general, I just want you all to know that although this is as I said, a quiet epidemic that's not getting the attention it deserves, that on a bipartisan basis, Senator Whitehouse, myself, and Senator Ayotte Klobuchar and others are going to ensure that this issue does get raised up and that we do help to provide better resources at the federal level to address it. Thank you all. Give you a little break.
Yeah. So to resume, I was just presenting some data on showing that the vast majority of both men and women don't seek some kind of help, whether it's treatment or other forms of intervention for their substance use disorders. But here we'll look at some data that show gender differences in that area. There are slight differences with regard to alcohol and drug problems, but generally the patterns are, as we can see, a higher proportion of women cite financial problems as a barrier, stigma, as we've been hearing about throughout the morning so far, and fear of treatment, fear of the consequences of treatment. That could be loss of custody, fear of legal consequences. Let's move on. Again, a similar pattern with drugs, but even more exacerbated, even more difference in terms of the fear and the stigma as barriers for treatment seeking. Moving on to the next slide. I think it's really important also to acknowledge that women as a group are not homogeneous, and there are lots of variability among women by age. And in this slide, we're looking at differences by race and ethnicity in terms of the barriers to seeking treatment. White women tend to be more likely to report stigma as a barrier or fear of treatment. African American women, much more likely to report structural barriers, lack of transportation, structural inability to access treatment. Treatment pessimism is also a factor for white women and African American women. Let's move on. Similar slide showing, in this case, the barriers by race and ethnicity for drug treatment. Stigma, again, looming very large, even more so than with regard to alcohol. And structural barriers predominating among African American and Latino women. So let's shift to when women actually go into treatment, where do they go? We see very different patterns by gender. We can move. Women are less likely than men to go into the traditional rehab program, and most likely that's because, as we saw earlier in the slides on prevalence, those rehab programs were designed with the assumption traditionally of a male client. And women are less likely to go into those programs. However, they're more likely to seek some kind of substance abuse treatment or to present that problem to a doctor, a social worker, a psychologist, as well as mental health settings. And that probably stems from the fact that women with substance use disorders tend to have higher rates of co-occurring mental health disorders, usually anxiety or depression. So they may present their substance use disorder to a mental health professional in mental health settings. Moving on, same data, but with regard to drug problems, even more exacerbated. Women less likely to go into the rehab programs for their drug problems, more likely to seek from a private caregiver. And also, I might note, less likely to participate in 8 or 12-step programs. And there are alternative models that have been designed to be more female-focused. So less availability to go, less likelihood to go into the traditional programs and models. So let's move on. This is actually data from a study I did based on a NIDA-funded multi-site study, where we went a little deeper into the psychosocial profiles that are associated with treatment access and utilization. It was very striking to me. If you look at the column on the left, for men, they cited their spouse was opposed to their substance use, but their family was highly supportive of them going into treatment. Or they had a referral through some kind of social system, their family, an employer, the criminal justice system. The profile for women is strikingly different. Treatment utilization for women was associated with factors that speak to the deficits that they have in social resources, single moms, women who initiated into treatment by themselves. They may have been imposed, in fact, by going into treatment by their spouses or partners, referral by a social worker, antisocial personality, and having been involved with sex work, factors that got them noticed above the radar, so to speak, contact with the criminal justice system. So the profile, very, very different in terms of not just willingness to seek treatment, but the support and resources for doing so. Let's move on. We know from a considerable amount of research that's in agreement that when women do go into a treatment program, they present with a profile of greater clinical severity. This is a very robust finding across many clinical studies. They have tended to move more quickly through the substance use and initiation, onset of dependence, moving into treatment. They have more clinical severity, more co-occurring mental health disorders, as I mentioned. They have more deficits with regard to employment and vocational skills. History of trauma and abuse, we'll hear more of that later on the other panel. HIV risk factors often higher than men because of their involvement in sex work or risky sex partners. Parenting responsibilities, child welfare involvement, and interpersonal problems and conflicts. So they present with a profile that the typical rehab models that were designed for male clients may not be prepared to address. So let's move on. So let's look at the treatment system and what's out there for women. If we look overall, you can move on, at the treatment system, approximately 8,000 treatment facilities, substance abuse treatment facilities in the United States. 35% of them, this is survey data collected by SAMHSA, state that they provide some special service or program for women. So slightly over 1/3 of the programs in our treatment system say that they do something to accommodate women's needs. I don't have to make the statement that that's shockingly low, and then we think back about the resistance, the fear, the barriers to treatment seeking, and in fact, when we look at the overall treatment system, it's a minority of those programs that have accommodated to some extent women's needs. What are they likely to do? This slide shows us the services that are available in those programs that say they have done some special programming, and I should add, I hate to say special, programming for women shouldn't be considered special, but they've done something to address women's needs. It's most often domestic violence services, about 32%, trauma-related, pregnancy and child care related. But as you can see, this is even a minority of those programs that are saying they do something to address women's needs. Let's move on. Back. With regard to treatment outcomes, there's been a plethora of studies that have addressed the issue of gender and treatment outcomes. This slide summarizes data from 38 studies and a meta-analysis looking at what are the common elements that are associated with improved retention and outcomes among women who do go into those treatment programs. And we can see they are the very services that I just showed you are lacking in our programs. So the services that address women's needs, child care, prenatal care and pregnancy, women-only programs, trained counselors who can address women's needs, specialized services, mental health services, longer and more intense services. I might also add, more recently, we have data that administering medication-assisted therapy, also beneficial to women, including during pregnancy. So we know the programs, the services that do better. We know they are also the minority of the programs in the treatment system. Move on. So this is just a simple bar graph showing very dramatically the difference in days retained in treatment among women in residential programs. You can see very dramatically in programs with childcare, child capacity, much more improved retention, and similarly, women who are in women-specific programs do much better in terms of retention. So what do we know about outcomes? The research is very mixed. Do men do better? Women do better? It's really not a simple answer to that question. Women do better in treatment when they get those services, when they get the specialized services that addresses that profile that I showed you a moment ago of the greater clinical severity, the co-occurring mental health problems, the vocational deficits. When they are treated in those programs, trauma-informed programs, they tend to do better. But a simple gender comparison often doesn't address that question because you're often looking at programs that don't include those evidence-based components. Let's move on. So I'm going to spend just a few minutes at the very end talking about system-level issues, because we can talk about women's fear of treatment and the fear of stigma, but part of it is what are the barriers they encounter when they do try to access treatment. We know there's limited capacity in terms of access to those programs that provide the specialized services for women. We know that often it's hard to get in the programs, and there's a wait list, particularly for a woman who has children and has logistical issues caring for her children. And we know that women come into treatment through various pathways, the criminal justice system, the child welfare system, the mental health system, and often those pathways are not coordinated, leading to fragmented care. So structural barriers, often their level of impairment may not be severe enough to merit going into treatment, so they have substance use problems, but with the limited capacity, they're not able to access it. Level of treatment availability, again, particularly related to childcare capacity, is limited, and limited coordination of care. We can go on. So this is just a graphic showing the interrelated pathways through treatment. We know that women are likely to enter treatment from any of these systems, and their treatment is improved with greater coordination of care across these systems so that their multiple problems can be addressed within the context of treatment. Next slide, please. So just to summarize, we know that men and women follow different pathways into treatment. They encounter different barriers when they attempt to access treatment, and they present with differing clinical profiles. We know from a great deal of evidence that the treatment services that address women's specific needs and are associated with better retention and outcomes. Yet we also know that most women with substance abuse problems not only do not seek treatment, but among those who do, they are unlikely to be able to access those specialized services because they do not exist throughout the treatment system in its entirety. So I will conclude at that point, and thank you for your attention.
Chris, that was great. You walked us through a lot of science very efficiently, and I really appreciate the points that you made. Our next presenter is Lori Chris. Lori is the Associate Director of the Ohio Council of Behavioral Health and Family Services, which is an organization that represents nonprofits that provide addiction treatment as well as prevention services, mental health, and family services and interventions. She has nearly 20 years of experience, particularly within the area of leadership for gender-specific addiction needs, trauma treatment, housing, and family services for women. Her current work extends into areas of recovery housing, opioid-affected pregnancies, and families that integrate physical and behavioral health care. She holds a master's degree of social work from Ohio State University, and she was one of the founding members of the Substance Abuse and Mental Health Administration's work group on women's sober housing and treatment, and she graduated from SAMHSA's Women's Addiction Services Leadership Institute. and she is here to talk to us a little bit about some of the work that is happening across her state. Lori.
Good morning. Thank you very much for the introduction. Really grateful to be here today and have the opportunity to share the learning that we've done in Ohio and across the country with some colleagues. As was said, I've worked in women's treatment for over 20 years, and the large emphasis of my work has been in operating and in working with other programs that operate treatment and housing that are specifically designed to meet the needs of women and their children. And so my comments today are really grounded in that work from my own experience and from the experience that we've collected from other providers with similar philosophies. Addiction, as Dr. Grella was saying, affects all impacts of a woman's life. And because of this, the programs that work with women are not just addressing their clinical treatment needs with addiction, they're also coordinating with primary care providers and hospitals and federally qualified health centers and clinics. They're working with pre-release centers and judges and drug courts and family courts and jails and prisons. They're working with family courts and caseworkers, GED programs, community colleges, local continuum of care, landlords, public housing authorities. You're getting the sense that a women's treatment program isn't just about addiction treatment. It's very broad and about a woman's overall health and wellness and her ability to function and really sustain wellness on a long-term basis through sobriety, through economic independence and stability, and through residential stability as well. And if a woman has children, these programs are also working with daycares and local school systems and helping families help children succeed in those environments. They're working with prevention programs and early intervention programs as well, so that these children and youth who are high risk for potential addiction in their future also have the opportunity to have a strong foundation for their own development as they move forward. So gender-specific treatment is more than just an individual psychotherapy session or medical attention and medication-assisted treatment. It's a program-based service that holistically meets the needs of women as they move through their recovery process. When I was, you mentioned that I founded the SAMHSA work group on women, housing, and treatment, and that opportunity created a network of women's treatment programs that also offer housing, safe and sober housing for women in recovery and for their children. And in that work, we had the opportunity to do some focus groups, some interviews, some in-person learning dialogues, and documented the outcomes from that work. There were several things that we identified as essential elements for effective programming and supports for women with addiction issues. The first was that they're women-focused, and Dr. Grella already spoke about that, but it's recognizing that not just that women experience addiction and recovery differently than men do, but also honoring the multiple roles that women have in their lives. So knowing that they're mothers, their wives, their partners, their daughters, their sisters, their neighbors, their employees, and that often they're themselves, they're women last, and they don't necessarily always focus on themselves. So it takes some creative attention to help them slow down and recognize that they need to do this not only for themselves, but for all the other folks in their lives and who are supportive of their recovery. These programs also emphasize the importance of alcohol and drug-free environments. Women need these abstinence-based environments that will help cushion them from a world where alcohol and drug use was the central focus of their day-to-day activities. And they need an opportunity to be in an environment where they can shift that focus to other healthy relationships and activities that they can pursue outside of drug and alcohol use. This may include a treatment center that's alcohol and drug-free, a drop-in center that's alcohol and drug-free, or recovery housing, a place to live and go back to 24/7 where they can find safety and security with other people who are in recovery, and that their children can find that stability as well. We know that it takes an extended time for someone to recover, that it's not just about getting the information, it's about practicing a newly acquired skill set and applying that on a day-to-day basis in their lives. So we need to move away from the idea that acute care is what works in addictions treatment, that someone can go into treatment for 7, 10, 30, 90 days and come out and be healed. That's not what works with recovery. It's not what works with recovery for women. They need an extended period of time, and it may be 2 to 5 years of ongoing recovery support, because it's a chronic disease like diabetes or MS, where people need the opportunity to plug into medical services occasionally for treatment or for checkups, where they need ongoing other recovery supports that will promote their long-term sobriety. Community was another essential element of the programs that we worked with. You may hear, if you're in or around the recovery community long enough, you may hear the phrase people, places, and things. Who we hang out with, where we go, the things that we do, those largely define who we are and create our identity and the opportunities that lie ahead of us in our lives. And we know that by providing a sense of community where women connect with other peers in recovery, with professionals who are focused on their wellness, and have that safe opportunity to be in a community where they'll be in an alcohol and drug-free environment and have that support for recovery, cannot be underestimated how powerful that is to supporting a woman in her long-term recovery. The communities that are created, these communities of recovery, have celebrations of recovery milestones or other successes, getting a GED. We've celebrated kids being potty trained. I mean, little life successes that don't always get celebrated are the things that a community of recovery and women's-specific treatment get celebrated on a day-to-day basis. We also have community meetings and peer support, and these are essential because isolation and loneliness are really the worst enemy of a person disabled by addiction. And women are often socialized not to trust one another. So through these communities of recovery, they connect to other people and they learn that they can have safe and healthy relationships with other women and with men in their lives. The programs we've worked with have recovery-oriented relapse policies, so they're flexible approaches to relapse so that women can create individualized care plans. We know that relapse is a time for assessment and re-engagement. It's not a time for termination from a program. We're also very focused on safety, so not just physical safety, but emotional and psychological safety as well. Many of the women in these programs have experienced significant trauma, and we'll hear about that later, and they've lived in environments where they haven't necessarily felt safe and comfortable, and their children haven't as well. These families express that this is the first time their kids could go to a neighbor's house and play, and they knew that they were safe. They knew there wouldn't be weapons or drugs or alcohol in that environment, and that it was a neighbor that they could trust. And we know that creating safety is also about facilitating independence and autonomy for the women, especially if they have a strong history of domestic violence or abuse. So supporting women in their own economic independence became part of the safety factor as well. Let me go back one more slide. I'm almost done with. Outcomes are focused beyond abstinence. So abstinence is a goal of recovery. It's a cornerstone of recovery, but it's not the only thing that will keep someone in long-term recovery or help someone achieve that. They need to be focused on healthy relationships and parenting. We know that the well-being of children is first and foremost on the minds of mothers who are in gender-specific treatment programs. And we know that kids would rather be nowhere else than with their mother and living with their mother. And so creating opportunities for family-centered interventions, for family support, is vital for gender-specific treatment. It's really hard for a mom to focus on her own wellness if she's not sure where her kids are, who they're living with, how they're doing in school. All of those things will rise to the front of her priorities if they're not together. And then employment becomes a significant part of these programs as well, or pursuit of purpose, because we really need to look at the culture of the women in the programs. There were some programs where intergenerational relationships existed in families. Women weren't necessarily going to work or pursuing employment. It was their role to be providing childcare so that other people could do that in their family. So helping them see what the most vital role is for them to exist within their family context. But many women are pursuing GEDs, going to community college, getting their now job that will help give them the income they need for rent and utilities and food, and pursuing their someday job that will give them the career that helps them thrive and really feel connected to the person they were meant to be. So as I looked at what we were talking about today and the programs and what they've said they need to do to generate their effective outcomes, I started to think about the policy barriers that make it difficult to design and operate these programs and make it difficult for people with substance use disorders to succeed in their recovery. First and foremost is that addiction is not recognized as a disability by the Social Security Administration. And this is a definition that is used in creating and managing other beneficiary programs. So when you hear people say people with disabilities have access to Medicaid, Medicare, Social Security income, housing, rent, and utility vouchers, vocational rehabilitation services, that's very true for people with severe mental disabilities, for severe physical disabilities, for developmental disabilities, but it's not true for a person who's primarily or solely disabled by substance use disorders. And I'm not suggesting that we change the definition with the Social Security Administration, but we need to know that when we embed that definition into program designs and resource allocation, we're excluding a large percentage of the population. 22 million people who have addiction are not able to access income, have access to medical services, have access to employment services that they vitally need, or rent and utility subsidies that they vitally need, even temporarily, in order to pursue and sustain their wellness. Two specific policies right now that are creating challenges in the recovery community and the treatment community are the Medicaid IMD rule, institutions for persons with mental disability. It's a 50-year-old rule that was originally created to help mitigate financial responsibility at the federal level for state psychiatric hospital inpatient stays, and eventually it was applied to residential treatment, inpatient treatment, and detox for substance use disorders as well. The practical outcome of this is that in order to operate a residential treatment program or a detox program and receive Medicaid so that you can serve low-income persons, you're capped at 16 beds. 16 beds is not enough capacity when you hear that there's been a 400% increase in opiate addiction in our country. We know that 16 beds can't meet that need, and we know that detox is often a vital first step for people with opiate addiction into their recovery. And it's also not a very smart business practice, frankly. 16 is not a cost-effective, that's not where any investor or business person would break off their cost-benefit analysis in operating that kind of service. So it really doesn't create an efficient business model either. The second is that HUD has begun to prioritize permanent housing in their efforts to end homelessness. And that's an evidence-based practice that's significantly valuable for a lot of populations. But for persons with substance use disorders, they need a range of housing choices that may include a transitional housing option that's more service-enriched than the permanent housing options that are available through HUD's resources. So in current practice, transitional housing is no longer part of the continuum of care homeless options, and local communities are beginning to close or shift transitional housing programs into a permanent housing model that isn't necessarily culturally or structurally appropriate for a person in early recovery. And so we're advocating for housing choice, and that a continuum of options needs to be available in local communities in order to meet the needs of people with substance use disorders. And in closing, I'd just like to highlight some of the policy actions that we're pursuing in Ohio and hoping to see pursued at the federal level as well. First of all, payment reform. we talked a lot about program-based services and the need for chronic disease management and outcome-based payment. And the current fee-for-service environment really doesn't allow for the flexibility and creativity that providers need, that systems need to meet the needs of women and their children in their recovery goals. And so payment reform is essential. We'd like HUD policies and resources that promote housing choice. We want both mainstream affordable housing that doesn't require an alcohol and drug-free environment and people can be motivated towards recovery, and we want alcohol and drug-free recovery-focused supportive service enriched environments where people who are in recovery can sustain that safe living environment. We're advocating for the elimination of the IMD rule, and we know that while this would take congressional action, and there are some proposals that are emerging right now, we also think there's some administrative policy changes that could bring more immediate relief. We need capacity in local communities today, and having a longer-term legislative fix might actually result in lost lives and unnecessary suffering. And then finally, we're supportive of continued investment in SAMHSA's Substance Abuse Prevention and Treatment Block Grant. These dollars are one of the largest investments in gender-specific women's treatment and prevention programs that our nation has, and they should be a source of pride for us, and they should be something that continues because they allow us to fund the glue that holds recovery together, those services that may not meet medical necessity, may not be covered by insurance, but definitely result in positive outcomes for women and for their children long term. So thank you very much for your time and attention.
Thank you, Lori. Our next speaker is Patricia Sams. She is the administrator for Building Hope Recovery Incorporated, which is a faith-based organization that promotes Celebrate Recovery Step meetings, outreach to individuals who are struggling with addiction in jails, prisons, and hospitals, transitional housing, and community services programs within the Stone County, Missouri, and surrounding areas. As vice president of this organization, she instructs members and provides continuing education on implementing best practices for peer-run organizations. She's a national speaker and a trainer. She has experience in training individuals in things like the use of medication-assisted treatment for alcoholism and opiate addiction. She also, very importantly, has 40 years of personal experience with generational alcoholism, successful completion of the Stone County DWI court program, along with medication-assisted treatment. She's maintained complete abstinence from alcohol and promotes a life in recovery. So she has rich experience to share with us this morning.
And thank you all for allowing me to come and represent millions of women who are still suffering from my story that I'm going to tell. And as I'm telling this story, please just keep in mind that my story is not unique. And everything that you hear is being played out at this very moment all the way from one end of the nation to the next. And this is a very, very serious epidemic. And I am so grateful that this opportunity to speak on behalf of women and that we are focusing on women and their needs has come to be. I am a generational alcoholic. I come from generations and generations where alcohol is just part of who we are. So growing up in an abusive family with an alcoholic father and all aunts and uncles, everything that we did, alcohol was involved. We were functioning, we were educated, we worked. You didn't miss work because you had a hangover. But the severity of the alcoholism in our family caused domestic violence on a regular basis. I watched family members die from the disease of alcoholism and drug addiction. And when I was younger, going through the tangled mess of what houses live in with alcoholic parents, my mother did not drink. She grew up in a family of drinkers. So she was the backbone of our family as far as working, and she was an enabler because she just didn't know any different. So growing up in that, I swore as a child that I was not going to grow up and be like that, and that I was not going to treat my children like that, and I wasn't going to have them in an environment like that. And the truth was, I grew up and I became just that. I was picked up for my 8th DUI when I was 40 years old. And leading up to that DUI, I became a mother, and I was incarcerated, combined 44 months between jail and prison for my drunk drivings. My son grew up with my mother after he was 9 through his teen years and his most impressionable years, and he watched me go in and out of jail, and he watched me escalate into a person that he didn't even know. The thing was, I would go into jail and I would come out and I continued to drink. And I would go back into jail and the cycle just continued because no one told me that I had a disease. And no one told me that if it was left untreated that it would progress and that I would build up a tolerance and that eventually I would drink myself to death. I knew that that was a possibility because I watched other family members do that. But I just thought that's who I was. So I continued to drink and I continued to go in and out of jail. And going back into jail, the officers would go, "Didn't you learn the last time?" Yeah, I learned how to make hooch. I learned about the alcohol content in our extracts that you use for cooking and vanilla, and that if I couldn't get to any alcohol, that I could drink these things until I could supply myself with more. NyQuil and drinking it really fast and the high alcohol content in that. Those are the things that I learned in jail. We didn't have 12-step programs in there. I learned about making your own wine. These are the things that I learned when I was in there. And actually, when I went to prison, I was given a certificate that I had successfully completed AA. Yeah. I think it was requirement by prison-run, inmate-run, that you just showed up for these meetings, and there was like 8 of them you had to sign your name to, and then you got this pretty certificate that said you graduated. So at that point, I was no longer an alcoholic because I had a degree to prove that. I went through the classes. The sad part about that is when I was released from prison, I made it 2 weeks before I was released from parole when I got another drunk driving. And the thing was, I had only white-knuckled it for 2 months after I was released. And I just could not drink. I didn't know why. By the time I was arrested for my 8th DUI in Stone County, I had been living in a room, and my alcoholism had escalated to the point that I couldn't function, and I couldn't move. I was using a bucket next to my bed to go to the bathroom because I couldn't make it to the bathroom. I was continuously waking up in my own vomit, and in order to just sit up, I had to drink. But I would throw that up, and I would just keep drinking until I kept it down because I couldn't sit up or move or do anything otherwise. I was going to sleep. I call it, so I was passing out, and each time I would start to fade out, I was praying that God would just take me. I had no quality of life. And during this time, leading up to this, my son started following in the same footsteps. But before that, he was very, very confused. He couldn't understand why mom loved alcohol more than him. He became a cutter, and he had to be institutionalized. At 17, he was arrested for possession of marijuana. And he was doing the same that I taught him, that my parents had taught me. And that was to medicate ourselves on things that we didn't understand. Judge Alan Blankenship, in the middle of the woods in Stone County, Missouri, is where I was arrested for my 8th DUI. And I was very sick. And that was when I was in that room. I don't remember that arrest. I remember waking up inside of a cell, and I was handcuffed to a pipe. And that's pretty severe. You're in a locked room, and you're handcuffed to a pipe. Judge Blankenship got all of my records, because the majority of my life I was from Michigan. And in Michigan, there wasn't any treatment, and it was jail at that time. And it was in and out of jail, and that was what they considered, that you were going to learn. You were going to get your incarceration time, and you were going to sit there long enough, and you were going to think about it, and then you were going to go out and be a productive member of society. So when he looked at my record, the assistant prosecutor was absolutely refusing to hear anything about treatment because I was an habitual offender and a huge, huge risk to society. So he wanted me to go and do 7 years prison. And Judge Blankenship presented my file to them, and he said, this lady has never had any help. She's never had any treatment. And the day that he looked at me in court, which was the first strange thing that ever happened in a courtroom for me, because a judge never, ever looked at me in the previous experiences that I had. But he looked at me, and he called me by my name, and he said, you need help, and we can help you. He made a phone call, and he got me into a treatment program. It was an inpatient treatment program. But when I was supposed to arrive for that, and I tried to quit drinking because I really wanted to do right by the judge in this opportunity. So I had quit drinking the night before. And I did not know at this time that severe intoxication of alcoholism and you just quit will kill you. So as I was getting ready to try and get there to the court, and I was really weak and I couldn't stand, I had lost body functions, and my body had started shutting down. And so I called the treatment center, and I told them that I think I have the flu. And they said, well, if judge said that you need to be in here, then the flu or no flu, you need to get in here. So it was really a good thing. I got there, and they had to send me to the hospital. I had 5 days of medical detox, and then I had 28 days into the residential program. Before I was to leave the program, I started getting really scared because I had never, ever been able to not drink. And I really didn't want to drink. Judge had sent over a request that I be screened for Vivitrol. And I had never heard anything about this medication. The only medications I heard about was the medication that you took, and then you would instantly throw up if you drank with it. And I didn't want any part of that. Because I really didn't think I wouldn't be able to not drink. And I was doing a pretty good job of making myself sick from alcohol on my own and doing that. So I sat down and I went through the screening process, and they gave me all the information on it. And I just wanted it. And they were offering me a chance at a sober life. So when I was released, I went to the clinic, and they gave me my first shot. And within 3 days, all of a sudden, my brain was quiet. For my whole life, there had always been something talking all the time about drinking. And then as I got older, and the more that I drank, the louder that voice was. And it was there for years. Everything that I did evolved around alcohol. All of my scheduling, all of our family events, everything evolved around drinking. And when that voice was gone, for a moment, I thought I finally snapped to not have that constant echo in my head. At that point, I started getting what they were telling me about 12 steps and about recovery. I could hear them. I could hear them when they were explaining to me about the disease of alcoholism and about setting the next steps in my life to be able to not be be caught in that addiction cycle any longer. I made a call to my son, who at that time was a grown man. Well, he was a grown boy. He was 20. And he hadn't talked to me in over a year because he was just done. And I asked him to come to Missouri, and I asked him to go through treatment because that's how it works. That's how it works. He didn't have a choice that I screwed him up. And I didn't want to give him a choice to get better. And the truth is, all he's ever wanted was just mom. He just wanted mom. So he came, and we went to counseling together. He was educated about the disease that is a potential hazard for him also, that he was going into the same pattern with. He stuck around. I have a grandson now, and he just graduated with his medical assistance degree, and he doesn't drink. And because of this program and the medical assistant treatment, I have broken the cycle of addiction in my family. My grandson doesn't even have a clue of what that generational cycle is, and he won't. I am grateful for all of you that work in the field, and I am especially grateful for this women's group coming together to focus on women. I am someone's daughter, sister, I'm a wife. Now, I'm a complete mother, and I'm a grandmother. The nation needs their mothers back. Thank you.
Thank you, Patricia, for your personal story. That is why I get out of bed and go to work every day. Our final speaker for this awesome panel is Trista Foreman, who is from the state of Rhode Island. She has an associate's degree in business management and is 4 months away from receiving her bachelor's degree in psychology with a focus on substance abuse. She is 28, she is married, and she is the mother of 2 girls. She lives in Warwick, Rhode Island, and she has struggled with substance use and addiction since she was 14 years old. She started using cocaine, and then she transitioned later to heroin. She began her drug use actually with her biological mother, who also had an addiction problem herself. She received help eventually from a behavioral health care nonprofit organization in Rhode Island where she entered into treatment, and she has been drug-free and living a life of recovery for the past 7 years.
Hi, everyone. I'd like to start off by saying that addiction, just as yours, has been in my family for generations. As you just heard, my mother was an addict and used with me. My grandmother raised me as a result of my mother being an addict, and she was incapable of raising me. I was her first child. Through the years, I watched her suffer, and coming by late hours, wanting money from my grandmother missing money and jewelry, and watching my grandmother sit up and cry because she felt so helpless and didn't know what to do for my mother. There was a period of time where my grandmother just kept her away because she didn't want it to affect me. But as I got older, I went and looked for her, and it did affect me because she was still very much an addict. And I attribute her and I using together to addiction and the terrible things that it can do to a family. By this time, she had 2 more children by the time her and I were using together. And when I would go to her house to use cocaine, there would be men in and out of the house. My little sister is a victim of sexual abuse because one of the men who actually fathered my youngest brother sexually abused her over and over and over. And my mother, when she told my mother didn't believe her and put her away. And now she has grown to be an addict as well as my other sister. I have a younger brother that's in and out of jail just because of the lifestyle that he's used to. I remember my mother bringing in a man one day that her and I were using and asking me if I would perform sexual acts in exchange for cocaine, and I did. I feel like that set the pace for me. I was already dealing with depression and anxiety, and I felt worthless, and I didn't feel good enough. And getting high made all that go away for a brief period of time. When I get high, I didn't think of any of that. Nothing mattered. And my mother and I actually experienced, if you can believe it, good times when we were high, if you can call them good times. And at that point, I treasured them because it was this bond that I had been longing for. Even though she was absent for a while during my younger days, I still always felt like I wanted her to be there, even though at that point I was seeing how the terrible things she was doing. And it was odd because I knew when we were getting high together, I knew it was wrong, but I still wanted to do it because I wanted to be with her. As I get older, around the age of 19, I graduated to using heroin. Heroin can sometimes be called the ultimate painkiller, and it was for me. It took everything. I ended up being homeless in the streets of Providence, wearing the same clothes for days and days on end. There were other women that were out there. There was a girl out there that was 16 years old, and she was prostituting herself so that she could get high. And it was this vicious cycle, because you'd go out, you'd hustle to get the money, and then you would get high, and then as soon as your high wore off, you would do it again. And it takes an enormous toll on women especially, men as well, but women especially. It takes a toll emotionally. It brings back those worthless feelings. There's also this, you're in this routine and you're comfortable with being uncomfortable, if that makes any sense. When I got arrested for shoplifting, I ended up going to jail, and I spent 60 days in jail and then was released on probation. I later violated my probation because at that point I wasn't offered any help yet, and I went right back out to using. When I violated my probation and got sent back to jail, I was put on work release. They would drop me off in the morning at a old person's home, at a nursing home, so that I could do the laundry in the back. And they would pick me up at the end of the day. One of those days, I was still sick from the heroin, and I was still detoxing. And I took off. I'm watching RIPTA, that's the local bus, go by every day, and I had had enough. I didn't want to be sick anymore. And I took the bus, and I ended up taking a little van. You pay them $30, and they take you to New York, and they drop you off. I didn't know anybody in New York. I just knew that I had just escaped from prison, and I needed to get out of Rhode Island. When they dropped me off, I didn't know where I was. Later, I found out I was in the South Bronx, on Hunts Point and Lafayette. And that's where I experienced some of the worst times I could ever imagine. Around there, you can't just walk around by yourself. Men pick you up. They beat you up. They try to make you prostitute yourself for them. They offer you more drugs so that they can get that grasp on you. By the time when detectives finally came and got me, I was sitting under stairs that you go up to get on the subway, and I had a little blanket, and I would sit there and panhandle because I couldn't walk the streets anymore. It was too dangerous. The men out there wouldn't allow it. And when the detectives came, I hugged him, and I leapt into his arms, and he carried me to the car, and I was so happy that he had came to get me. I was so happy to be going back home to Rhode Island. When I came back home, my grandmother, who was still alive at that point, had asked me if I was ready yet. And I told her that I was. And she took me to Kodak in Providence. And if it wasn't for them, I would have never been able to get clean and off the streets and out of that terrible cycle. I got on methadone, and soon after, I got myself in school. My husband is in recovery as well, and we started the journey of getting clean together and experiencing all the wonderful little things that we had missed while we were out there. Starting a family, having rent to pay, using bathrooms with running water, all those little things that you take for granted when you're homeless and using drugs. I graduated with my associate's degree, and then later on I decided that I wanted to play a part in the lives of women, particularly young women, that are using drugs and caught in that vicious cycle of homelessness and drugs and prostitution and all the things that women have to do to get by when they're out there. And I went back, and now I'm, as she said, in pursuit of a bachelor's degree in psychology with the focus on substance abuse. And I can't wait to help women overcome addiction. Thank you.
You know, as people were speaking and the clock was ticking, Trista said to me, now, if you don't have time for me, that's okay. And I said, we're going to make time for you. And I'm really glad that we did. So I think we have time for some questions. We're going to take about 10 minutes for people to ask questions. And because this is being recorded, I'm going to have to repeat the question for the panelists. So if anyone has questions at this time, please stand. So let me try to paraphrase your questions. The first one had to do with the Affordable Care Act and healthcare reform efforts across the country, and the fact that in many cases, insurance companies are not necessarily informed about evidence-based practices for addiction treatment. And so what can be done to help disseminate that kind of information to ensure that this is actually a lever that we can use for uptake of evidence-based treatment? And then the second question I've already lost track of. Oh, primary care. What can be done to address substance use and addiction within primary care settings? So we'll let Chris start. Sure.
Your questions are exactly where the field of substance abuse treatment, particularly the division that Radonna is acting director of Epidemiology Services and Prevention at NIDA, because our number one issue is how to move addiction treatment, evidence-based addiction treatment, into those settings, such as federally qualified health centers, how to get better coordination of care between addiction providers who will see an increase in those who now have public insurance coverage so they can access treatment, and trying to educate the workforce to keep up with that increase in what we're expecting to see within both primary care settings where people under ACA can be screened for alcohol problems, not illicit drug problems. That's not covered in the current ACA mandate. We would like to see an expansion for coverage of drug screening as well. But your questions, I have to applaud. You are exactly where the field is going, how to integrate the evidence-based practices within primary health care and the broader array of service delivery systems through the healthcare system. My concern is that we need to be advocating for women's treatment within those policy changes. I don't know that it's being highlighted, which is why I'm thrilled to see this forum today, that women's treatment needs and evidence-based practices need to be part of those policy changes.
So in addition to that, there's policy work around payment reform, and when I talked about that earlier, it could drive some of the changes. You know, what gets paid for gets done. And right now, in a fee-for-service environment, it's very focused on an acute care model and very focused on short-term interventions, minimizing expenses, and then best of luck after that. And so with some well-thought-out payment reform that's more outcome-based and could really drive practices towards chronic disease management and overall health for a person, not just their addiction recovery. That's what we're looking for. There are pilot projects for that with mental health and severe mental disability, but it's in Ohio, at least, we don't have any significant projects that are directed specifically towards that type of work for substance use disorders. And so the readiness of providers is not rapidly accelerating at the rate that it needs to for the competitive environment that's starting. Ohio does have a project that they're starting now called the Moms Project, and Margot Spence is here, and she'll talk about that. And it does have more of that comprehensive approach to care in an integrated setting with primary care and addiction as a specialty treatment provider with some creative payment mechanisms that hopefully we'll be able to learn from and transfer knowledge to as well.
So the question is, how do you address the needs of women with children and the provision of safe care and perhaps even being able to have children with their mothers when they are participating in treatment when there's a lack of a payment stream?
First, I want to confirm exactly what you said. The survey data that I showed that looks at the services that are provided for women across the treatment system, and there were 35% that provided some services for women, has been remarkably consistent over time and has been decreasing. So as shocking as it is that that's a small portion of the treatment system, it has decreased. There was a flurry of attention to the issue of pregnancy and substance use in the 80s with the prevalence of cocaine use. That has reduced. And SAMHSA does have a Pregnant and Parenting Women's Initiative where they fund programs to provide these enhanced services. Maybe they fund 12 to 15 programs for 3 years, and that's a drop in the bucket. So you're absolutely right. I think this is where we need policy and advocacy. If we look at the states do have standards for how their block grant funds are spent with regard to women's services. There has been a lot of analysis of the state block mandate. It is highly variable. There are no consistent standards for the treatment of women, pregnant women, parenting women. States have tremendous discretion around that, and there's no mandates to enforce the standards that do exist. Furthermore, with the Medicare waiver through the Affordable Care Act, Many states have not expanded their public insurance systems, creating even more disparity. So clearly, to me, what you said is correct. We know from our research the evidence-based practices that are effective. So this is an area for policy and advocacy.
And I think we need to be very clear in our messaging around this. When Patricia said the nation needs their mothers back, that's absolutely right. And when Trista talked about the experience that she had in communities with how she was preyed upon by men, I mean, women don't get well unless communities are well, and women don't get well unless men are well. And we need to approach this as a family-centered issue. And yes, there are specific evidence-based practices that should be financed and endorsed for women in their own wellness, but we have to have a collective approach to this. In Ohio, we've started to look at it, frankly, as a jobs issue. I mean, if people are suffering from a disease and we have a public health crisis that's risen to the level that it has, we don't have communities that attract businesses. We don't have people who are able to work. And in framing it that way, we've been able to have new investments in addiction treatment services and new investments in prevention services. We have 15 different pieces of legislation around opiate addiction and other recovery supports right now. So I think really making it a community issue rather than an addiction issue will help us move things forward too.
So 2 questions. The first was, what do we know from a research and evidence-based perspective about the unique biological components of addiction and treatment for women? And then the second, what do we know about evidence-based approaches for treating women across the lifespan and as they age? I'll start out by saying one thing. At NIDA and at the NIH at large, we have an increased focus right now at looking at the portfolio of research that we support, all the way from basic science through to the development of treatment interventions, and trying to ensure that we are looking at issues that are unique at a biological level for males and females, even at the level of the cell. So I am often in the room with my institute director, Dr. Nora Volkoff, where she is asking, if someone's presenting a study on a sample of 500, how many of those are women? Do you have any data specific to women? So these are questions that we are aware need to be addressed and that we are beginning to look at and to address. And there are some unique aspects related to women from a biological perspective that have bearing on treatment, and I'll let Chris follow up.
Yes, I do think that is an area that is in tremendous need of development, and there is fabulous research going on in the area, particularly of epigenetics and gender and brain mechanisms. We're starting to see it. It's very slow. Where we have the best evidence, I think, is with regard to treatment of pregnant women, and later on we'll hear Dr. Andre Jones, who is an expert and will be able to address the issues of treating pregnant women. And medications in particular, how medications work differently for men and women, and particularly considering pregnant women, which is an incredibly important area where we do have some evidence. But from the etiology of addiction and how that may differ for women, that's one of the areas where we need more science, and it is beginning. I do want to say one word about the lifespan issue. We are not addressing adolescent girls for the most part today. They have tremendously different issues. We know throughout the lifespan, if women present to substance abuse treatment with more severe disorders, that is the same, if not more so, for adolescent girls who initiate use now increasingly earlier, presenting with more severe problems. For older women, we've been talking a lot about prescription drug abuse. Here is the big secret. Older women are abusing prescription medications and alcohol to much higher rates compared to their older male counterparts. So another invisible, hidden crisis that's developing.
Okay, so our time is up. I think that many of the panelists will be staying for the rest of the morning, so those of you who had questions, please take the opportunity to speak with them. I want to thank everyone for being here today, for the work that you are doing, whether it is in science, whether it is in policy, advocacy, and treatment, whether it is in building your own healthy family and community. You're very inspirational. As I said earlier, remind me about why I get up every day and go to work. So it's been a pleasure to spend some time with you all this morning. Thank you.